the respiratory system to be less efficient. Any changes in rate or type of breathing should be reported immediately. Blood pressure. Arterial blood pressure is a measure of the pressure exerted by the blood as it flows through the arteries. Because the blood moves in waves, there are two blood pressure measurements. The systolic pressure is the pressure of the blood as a result of contraction of the ventricles, that is, the pressure of the height of the blood wave. The diastolic pressure is the pressure when the ventricles are at rest. Diastolic pressure, then, is the lower pressure, present at all times within the arteries. The difference between the diastolic and the systolic pressures is called the pulse pressure. A normal pulse pressure is about 40 mmHg, but can be as high as 100 mmHg during exercise. Blood pressure is measured in millimeters of mercury, mmHg, and recorded as a fraction, systolic pressure over the diastolic pressure. A typical blood pressure for a healthy adult is 120/80 mmHg, pulse pressure of 40. Because blood pressure can vary considerably among individuals, it is important for the nurse to know a specific client's baseline blood pressure. For example, if a client's usual blood pressure is 180/100 mmHg, and it is assessed following surgery to be 120/80 mmHg, this significant drop in pressure may indicate comply. Cations and must be reported to the primary care provider. A consistently elevated pulse pressure occurs in arteriosclerosis. A low pulse pressure, example, less than 25 mmHg, occurs in conditions such as severe heart failure. Sometimes, it is useful to also determine the mean arterial pressure, MAP, because this represents the home care considerations. Respirations. Monitor respiratory rate following the administration of respiratory depressants, such as morphine. Assess the home setting for factors that could interfere with breathing, such as exhaust, gas, or paint fumes, or individuals who smoke. If the client has just come in from another room, allow the client to rest a minute or two before counting respirations. Have an adult hold a child gently to reduce movement while counting respirations. Safety. M29B_Berm 4362_10_SE_CH29. 499 February 12, 14, 5:51 p.m. 500 Unit 7 Assessing Health. Number 153613 CUST, Pearsono, Berman PG Number 500 Title, Kosier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Pressure actually delivered to the body's organs. The MAP can be calculated in several different ways, one of which is to add 2/3 of the diastolic pressure to 1/3 of the systolic pressure. A normal MAP is 70 to 110 mmHg. Determinants of blood pressure. Arterial blood pressure is the result of several factors: the pumping action of the heart, the peripheral vascular resistance, the resistance supplied by the blood vessels through which the blood flows, and the blood volume and viscosity. Pumping action of the heart. When the pumping action of the heart is weak, less blood is pumped into arteries, lower cardiac output, and the blood pressure decreases. When the heart's pumping action is strong, and the volume of blood pumped into the circulation increases, higher cardiac output, the blood pressure increases. Peripheral vascular resistance. Peripheral resistance can increase blood pressure. The diastolic pressure especially is affected. Some factors that create resistance in the arterial system are the capacity of the arterioles and capillaries, the compliance of the arteries, and the viscosity of the blood. The internal diameter or capacity of the arterioles and the capillaries determines in great part the peripheral resistance to the blood in the body. The smaller the space within a vessel, the greater the resistance. Normally, the arterioles are in a state of partial constriction. Increased vasoconstriction, such as occurs with smoking, raises the blood pressure, whereas decreased vasoconstriction lowers the blood pressure. If the elastic and muscular tissues of the arteries are replaced with fibrous tissue, the arteries lose much of their ability to constrict and dilate. This condition, most common in middle-aged and older adults, is known as arteriosclerosis. Blood volume. When the blood volume decreases, for example, as a result of a hem or hage, or dehydration, the blood pressure decreases because of decreased fluid in the arteries. Conversely, when the volume increases, for example, as a result of a rapid intravenous infusion, the blood pressure increases because of the greater fluid volume within the circulatory system. Blood viscosity. Blood pressure is higher when the blood is highly viscous, thick, that is, when the proportion of red blood cells to the blood plasma is high. This proportion is referred to as the hematocrit. The viscosity increases markedly when the hematocrit is more than 60% to 65%. Factors affecting blood pressure. Among the factors influencing blood pressure are age, exercise, stress, race, gender, medications, obesity, diurnal variations, medical conditions, and temperature. Age. Newborns have a systolic pressure of about 75 mmHg. The pressure rises with age, reaching a peak at the onset of puberty, and then tends to decline somewhat. In older adults, elasticity of the arteries is decreased, the arteries are more rigid, and less yield to the pressure of the blood. This produces an elevated systolic pressure. Because the walls no longer retract as flexibly with decreased pressure, the diastolic pressure may also be high. Exercise. Physical activity increases the cardiac output, and hence the blood pressure. For reliable assessment of resting blood pressure, wait 20 to 30 minutes following exercise. Stress. Stimulation of the sympathetic nervous system increases cardiac output and vasoconstriction of the arterioles, thus increasing the blood pressure reading. However, severe pain can decrease blood pressure greatly by inhibiting the vasomotor center and producing vasodilation. Race. African Americans older than 35 years tend to have higher blood pressures than European Americans of the same age, although the exact reasons for these differences are unclear. Covelli, Wood, and Urandi, 2012. Sex. After puberty, females usually have lower blood pressures than males of the same age. This difference is thought to be due to hormonal variations. After menopause, women generally have higher blood pressures than before. Medications. Many medications, including caffeine, may increase or decrease the blood pressure. Obesity. Both childhood and adult obesity predispose to hypertension. Diurnal variations. Pressure is usually lowest early in the morning, when the metabolic rate is lowest, then rises throughout the day, and peaks in the late afternoon or early evening. Medical conditions. Any condition affecting the cardiac output, blood volume, blood viscosity, and/or compliance of the arteries has a direct effect on the blood pressure. Temperature. Because of increased metabolic rate, fever can increase blood pressure. However, external heat causes vasodilation and decreased blood pressure. Cold causes vasoconstriction and elevates blood pressure. Hypertension. A blood pressure that is persistently above normal is called hypertension. A single elevated blood pressure reading indicates the need for reassessment. Hypertension cannot be diagnosed unless an elevated blood pressure is found when measured twice at different times. It is usually asymptomatic and is often a contributing factor to myocardial infarctions, heart attacks. An elevated blood pressure of unknown cause is called primary hypertension. An elevated blood pressure of known cause is called secondary hypertension. Hypertension is a widespread health problem. Individuals with diastolic blood pressures of 80 to 89 mmHg or systolic blood pressures of 120 to 139 mmHg should be considered prehypertensive and, without intervention, may develop cardiac disease. Hypertension is when either the systolic BP is higher than 140 mmHg or when the diastolic blood pressure, BP, is 90 mmHg or higher, see Table 29-4. The stage of hypertension is determined by the higher of the two values. For example, if either of the systolic or diastolic values falls in the stage 2 range, stage 2 hypertension is assigned. Factors associated with hypertension include thickening of the arterial walls, which reduces the size of the arterial lumen and inelasticity of the arteries, as well as such lifestyle factors as cigarette smoking, obesity, heavy alcohol consumption, lack of physical exercise, high blood cholesterol levels, and continued exposure to stress. The national guidelines for high blood pressure management recommend that hypertensive individuals age 60 years or older. M29B_Berm 4362_10_SE_CH29.IND 500 February 12, 14, 5:51 p.m. Chapter 29 Vital Signs 501. Number 153613 CUST, Pearson, Berman PG Number 501 Title, Kosier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Receive treatment toward a goal of less than 150/90 mmHg, and hypertensive individuals age 30 through 59 years have a diastolic goal of less than 90 mmHg. For all other individuals, the goal is less than 140/90 mmHg. James et al., 2014. Hypotension. Hypotension is a blood pressure that is below normal, that is, a systolic reading consistently between 85 and 110 mmHg in an adult whose normal pressure is higher than this. Orthostatic hypotension is a blood pressure that decreases when the client sits or stands. It is usually the result of peripheral vasodilation, in which blood leaves the central body organs, especially the brain, and moves to the periphery, often causing the person to feel faint. Hypotension can also be caused by analgesics such as meperidine hydrochloride, Demerol, bleeding, severe burns, and dehydration. It is important to monitor hypotensive clients carefully to prevent falls. When assess ING for orthostatic hypotension. Place the client in a supine position for 10 minutes. Record the client's blood pressure. Assist the client to slowly sit or stand. Support the client in case of faintness. Immediately recheck the blood pressure in the same sites as previously. Repeat the pulse and blood pressure after 3 minutes. Record the results. A drop in blood pressure of 20 mmHg systolic or 10 mmHg diastolic indicates orthostatic hypotension, major, 2012. Assessing blood pressure. Blood pressure is measured with a blood pressure cuff, a sphygmomanometer, and a stethoscope. The blood pressure cuff consists of a bag, called a bladder, that can be inflated with air, figure 29 to 18. It is covered with cloth and has 2 tubes attached to it. One tube connects to a bulb that inflates the bladder. A small valve on the side of this bulb traps and releases the air in the bladder. The other tube is attached to a sphygmomanometer. The sphygmomanometer indicates the pressure of the air within the bladder. There are 2 types of sphygmomanometers, aneroid and digital. The aneroid sphygmomanometer has a calibrated dial, with a needle that points to the calibrations, figure 29 to 19. Many agencies use digital, electronic, sphygmomanometers, figure 29 to 20, which eliminate the need to listen for the sounds of the client's systolic and diastolic blood pressures through cuff, valve, bulb, tube to sphygmomanometer. A. B. Bladder length. Cuff bladder. Bladder width. Figure 29 to 18A, blood pressure cuff and bulb. B. Bladder inside the cuff. Figure 29 to 19 blood pressure equipment, an aneroid manometer and cuff. A stethoscope. Electronic blood pressure devices should be calibrated periodically to check accuracy. All healthcare facilities should have manual blood pressure equipment available as backup. Doppler ultrasound stethoscopes are also used to assess blood pressure, see figure 29 to 15. These are of particular value when blood pressure sounds are difficult to hear, such as in infants, obese clients, and clients in shock. Systolic pressure may be the only blood pressure obtainable with some ultrasound models. Blood pressure cuffs come in various sizes, because the bladder must be the correct width and length for the client's arm, figure 29 to 21. If the bladder is too narrow, the blood pressure reading will be erroneously elevated. If it is too wide, the reading will be erroneously low. The width should be 40% of the circumference, or 20% wider than the diameter of the midpoint of the limb. Category systolic BP, mmHg, diastolic BP, mmHg, normal 120 and 80 pre-hypertension 120 to 139 or 80 to 89 hypertension, stage 1 140 to 159 or 90 to 99 hypertension, stage 2 greater than 160 or 100 from the 7th report of the Joint National Committee for the Detection, Evaluation, and Treatment of High Blood Pressure, completed report by National Institutes of Health, National Heart, Lung, and Blood Institute, 2004. Retrieved from http://www.nhl.by.nih.gov/guidelines/hypertension/jnc7full.htm. Table 29 to 4 Classification of blood pressure. M29B_Berm 4362_10_SE_CH29.IND 501 February 12, 14, 5:51 p.m. 502 Unit 7 Assessing Health. Number 153613 CUST, Pearson O. Berman PG Number 502 Title, Kosier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Blood pressure assessment cites the blood pressure is usually assessed in the client's upper arm using the brachial artery and a standard stethoscope. Assessing the blood pressure on a client's thigh is indicated in these situations. The blood pressure cannot be measured on either arm, example, because of burns or other trauma. The blood pressure in one thigh is to be compared with the blood pressure in the other thigh. Blood pressure is not measured on a particular client's limb in the following situations. The shoulder, arm, or hand, or the hip, knee, or ankle, is injured or diseased. A cast or bulky bandage is on any part of the limb. The client has had surgical removal of breast or axillary, or inguinal, lymph nodes on that side. The client has an intravenous infusion or blood transfusion in that limb. The client has an arteriovenous fistula, example, for renal dialysis, in that limb. Methods: blood pressure can be assessed directly or indirectly. Direct, invasive monitoring, measurement involves the insertion of a catheter into on which it is used. The arm circumference, not the age of the client, should always be used to determine bladder size. The nurse can determine whether the width of a blood pressure cuff is appropriate. Lay the cuff lengthwise at the midpoint of the upper arm, and hold the outermost side of the bladder edge laterally on the arm. With the other hand, wrap the width of the cuff around the arm, and ensure that the width is 40% of the arm circumference, figure 29 to 22. The length of the bladder also affects the accuracy of measurement. The bladder should be sufficiently long to cover at least 2/3 of the limb's circumference. For obese clients, a standard-sized bladder in an extra-long cuff may be the most appropriate. McFarlane, 2012. Blood pressure cuffs are made of non-distensible material, so that an even pressure is exerted around the limb. Most cuffs are held in place by hooks, snaps, or hook and loop fabric. Others have a cloth bandage that is long enough to encircle the limb several times. This type is closed by tucking the end of the bandage into one of the bandage folds. Finger sensor for pulse and O2 saturation. Thermometer. Digital display of systolic and diastolic BP, temperature, pulse, and O2 saturation. Figure 29 to 20 Electronic blood pressure monitors register blood pressures. Figure 29 to 21 Standard cuff sizes. Smaller cuffs are used for infants, small children, or frail adults. Mid-size cuffs are used for most adults, and larger cuffs are used for measuring the blood pressure on the leg or arm of an adult who is obese. Bladder of cuff. Figure 29 to 22 determining that the bladder of a blood pressure cuff is 40% of the arm circumference, or 20% wider than the diameter of the midpoint of the limb. M29B_Berm 4360-10_SE_CH29.IND 502 February 12, 14, 5:51 p.m. Chapter 29 Vital Signs 503. Number 153613 CUST, Pearson, Berman PG Number 503 Title, Kosier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Particularly in hypertensive clients, is the temporary disappearance of sounds normally heard over the brachial artery when the cuff pressure is high, followed by the reappearance of the sounds at a lower level. This temporary disappearance of sounds occurs in the latter part of Phase 1 and Phase 2 and may cover a range of 40 mmHg. If a palpated estimation of the systolic pressure is not made prior to AU auscultation, the nurse may begin listening in the middle of this range and underestimate the systolic pressure. In the palpatory method of blood pressure determination, instead of listening for the blood flow sounds, the nurse uses light to moderate pressure to palpate the pulsations of the artery as the pressure in the cuff is released. The pressure is read from the sphygmomanometer when the first pulsation is felt. A single whip-like vibration, felt in addition to the pulsations, identifies the point at which the pressure in the cuff nears the diastolic pressure. This vibration is no longer felt when the cuff pressure is below the diastolic pressure. Common errors in assessing blood pressure. The importance of the accuracy of blood pressure assessments cannot be overemphasized. Many judgments about a client's health are made based on blood pressure. It is an important indicator of the client's condition and is used extensively as a basis for nursing interventions. Two possible reasons for blood pressure errors are hurrying on the part of the nurse and subconscious bias, in which a nurse may be influenced by the client's previous blood pressure measurements or diagnosis and hear a value consistent with the nurse's expectations. Some reasons for erroneous blood pressure readings are given in Table 29-5. Skill 29-6 provides guidelines for assessing blood pressure. The brachial, radial, or femoral artery. Arterial pressure is represented as wave-like forms displayed on a monitor. With correct placement, this pressure reading is highly accurate. Two non-invasive indirect methods of measuring blood pressure are the auscultatory and palpatory methods. The auscultatory method is most commonly used in hospitals, clinics, and homes. External pressure is applied to a superficial artery, and the nurse reads the pressure from the sphygmomanometer while listening with a stethoscope. When carried out correctly, the auscultatory method is relatively accurate. When taking a blood pressure using a stethoscope, the nurse identifies phases in the series of sounds called Korotkoff sounds, Figure 29-23. 5 phases occur but may not always be audible, Box 29-6. The systolic pressure is the point where the first tapping sound is heard, Phase 1. In adults, the diastolic pressure is the point where the sounds become inaudible, Phase 5. The Phase 5 reading may be 0, that is, the muffled sounds are heard even when there is no air pressure in the blood pressure cuff. For complete accuracy, the Phase 4 and 5 readings should be recorded. The palpatory method is sometimes used when Korotkoff sounds cannot be heard and electronic equipment to amplify the sounds is not available, or to prevent misdirection from the presence of an auscultatory gap. An auscultatory gap which occurs. Korotkoff phases. Phase 1. Phase 2. Phase 3. Phase 4. Phase 5. A sharp tapping. A swishing or whooshing sound. A thump softer than the tapping in Phase 1. A softer blowing muffled sound that fades. Silence. 140. 130. 120. 110. 100. 90. 80. Figure 29 to 23 Korotkov sounds can be differentiated into 5 phases. In the illustration, the blood pressure is 138/90 or 138/102/90. Box 29 to 6 Korotkov sounds. Phase 1, the pressure level at which the first faint, clear tapping or thumping sounds are heard. These sounds gradually become more intense. To ensure that they are not extraneous sounds, the nurse should identify at least 2 consecutive tapping sounds. The first tapping sound heard during deflation of the cuff is the systolic blood pressure. Phase 2, the period during deflation when the sounds have a muffled, whooshing, or swishing quality. Phase 3, the period during which the blood flows freely through an increasingly open artery, and the sounds become crisper and more intense, and again assume a thumping quality, but softer than in Phase 1. Phase 4, the time when the sounds become muffled and have a soft, blowing quality. Phase 5, the pressure level when the last sound is heard. This is followed by a period of silence. The pressure at which the last sound is heard is the diastolic blood pressure in adults, asterisk. Asterisk in agencies where the fourth phase is considered the diastolic pressure, 3 measures are recommended, systolic pressure, diastolic pressure, and Phase 5. These may be referred to as systolic, first diastolic, and second diastolic pressures. The Phase 5, second diastolic pressure, reading may be 0, that is, the muffled sounds are heard even when there is no air pressure in the blood pressure cuff. In some instances, muffled sounds are never heard, in which case a dash is inserted where the reading would normally be recorded, example, //110. M29B_berm 4362_10_SE_CH29.IND 503 February 12, 14, 5:51 p.m. 504 Unit 7 Assessing Health. Number 153613 CUST, Pearson O. Berman PG Number 504 Title, Kosier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Table 29 to 5 Selected Sources of Error in Blood Pressure Assessment. Error effect bladder cuff too narrow erroneously high. Bladder cuff too wide erroneously low. Arm unsupported erroneously high. Insufficient rest before the assessment erroneously high. Repeating assessment too quickly erroneously high systolic or low diastolic readings. Cuff wrapped too loosely or unevenly erroneously high. Deflating cuff too quickly erroneously low systolic and high diastolic readings. Deflating cuff too slowly erroneously high diastolic reading. Failure to use the same arm consistently inconsistent measurements. Arm above level of the heart erroneously low. Assessing immediately after a meal, or while client smokes, or has pain erroneously high. Failure to identify auscultatory gap erroneously low systolic pressure, and erroneously low diastolic pressure. Purpose to obtain a baseline measurement of arterial blood pressure for subsequent evaluation to determine the client's hemodynamic status, example, cardiac output, stroke volume of the heart, and blood vessel resistance. To identify and monitor changes in blood pressure resulting from a disease process, or medical therapy, example, presence or history of cardiovascular disease, renal disease, circulatory shock, or acute pain, rapid infusion of fluids or blood products. Assessment assess signs and symptoms of hypertension, example, headache, ringing in the ears, flushing of face, nosebleeds, fatigue, signs and symptoms of hypertension, example, tachycardia, dizziness, mental confusion, restlessness, cool and clammy skin, pale or cyanotic skin. Factors affecting blood pressure, example, activity, emotional stress, pain, and time the client last smoked or ingested caffeine. Some blood pressure cuffs contain latex. Assess the client for latex allergy and obtain a latex-free cuff if indicated. Planning delegation. Blood pressure measurement may be delegated to UAP. The interpretation of abnormal blood pressure readings, and determination of appropriate responses are done by the nurse. Interprofessional practice. Measurement of blood pressure is within the scope of practice for many healthcare providers. For example, in addition to nurses, therapists may check the client's blood pressure before, during, and after treatment. Although these therapists may verbally communicate their findings and plan to the healthcare team members, the nurse must also know where to locate their documentation in the client's medical record. Equipment: stethoscope or DUS, blood pressure cuff of the appropriate size, sphygmomanometer. Implementation preparation 1. Ensure that the equipment is intact and functioning properly. Check for leaks in the tubing between the cuff and the sphygmomanometer. 2. Make sure that the client has not smoked or ingested caffeine within 30 minutes prior to measurement. Rationale: smoking constricts blood vessels, and caffeine increases the pulse rate. Both of these cause a temporary increase in blood pressure. Performance 1. Prior to performing the procedure, introduce self and verify the client's identity using agency protocol. Explain to the client what you are going to do, why it is necessary, and how he or she can participate. Discuss how the results will be used in planning further care or treatments. 2. Perform hand hygiene and observe appropriate infection prevention procedures. 3. Provide for client privacy. 4. Position the client appropriately. The adult client should be sitting unless otherwise specified. Both feet should be flat on the floor. Rationale: legs crossed at the knee results in elevated systolic and diastolic blood pressures. Pinar, Atalkin, and Watson, 2010. Assessing blood pressure. Skill 29, 6. M29B_Berm 4362_10_SE_CH29.IND 504 February 12, 14, 5:51 p.m. Chapter 29 Vital Signs 505. Number 153613 CUST, Pearson, Berman PG Number 505 Title, Kosier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Assessing blood pressure, continued. Skill 29-6. The elbow should be slightly flexed with the palm of the hand facing up, and the arm supported at heart level. Readings in any other position should be specified. The blood pressure is normally similar in sitting, standing, and lying positions, but it can vary significantly by position in certain persons. Rationale: the blood pressure increases when the arm is below heart level and decreases when the arm is above heart level. Expose the upper arm. 5. Wrap the deflated cuff evenly around the upper arm. Locate the brachial artery, see Figure 29-13, page 487. Apply the center of the bladder directly over the artery. Rationale: the bladder inside the cuff must be directly over the artery to be compressed if the reading is to be accurate. For an adult, place the lower border of the cuff approximately 2.5 centimeters 1 inch above the antecubital space. 6. If this is the client's initial examination, perform a preliminary palpatory determination of systolic pressure. Rationale: the initial estimate tells the nurse the maximal pressure to which the sphygmomanometer needs to be elevated in subsequent determinations. It also prevents underestimation of the systolic pressure or overestimation of the diastolic pressure, should an auscultatory gap occur. Palpate the brachial artery with the fingertips. Close the valve on the bulb. Pump up the cuff until you no longer feel the brachial pulse. At that pressure the blood cannot flow through the artery. Note the pressure on the sphygmomanometer at which pulse is no longer felt. Rationale: this gives an estimate of the systolic pressure. Release the pressure completely in the cuff, and wait 1 to 2 minutes before making further measurements. Rationale: a waiting period gives the blood trapped in the veins time to be released. Otherwise, false high systolic readings will occur. 7. Position the stethoscope appropriately. Cleanse the earpieces with antiseptic wipe. Insert the ear attachments of the stethoscope in your ears. so that they tilt slightly forward. Rationale: sounds are heard more clearly when the ear attachments follow the direction of the ear canal. Ensure that the stethoscope hangs freely from the ears to the diaphragm. Rationale: if the stethoscope tubing rubs against an object, the noise can block the sounds of the blood within the artery. Place the bell side of the amplifier of the stethoscope over the brachial pulse site. Rationale: because the blood pressure is a low-frequency sound, it is best heard with the bell-shaped diaphragm. Place the stethoscope directly on the skin, not on clothing over the site. Rationale: this is to avoid noise made from rubbing the amplifier against cloth. Hold the diaphragm with the thumb and index finger. 8. Auscultate the client's blood pressure. Pump up the cuff until the sphygmomanometer reads 30 mmHg above the point where the brachial pulse disappeared. Release the valve on the cuff carefully so that the pressure decreases at the rate of 2 to 3 mmHg per second. Rationale: if the rate is faster or slower, an error in measurement may occur. As the pressure falls, identify the manometer reading at Korotkoff phases 1, 4, and 5. Rationale: there is no clinical significance to phases 2 and 3. Deflate the cuff rapidly and completely. Wait 1 to 2 minutes before making further determinations. Rationale: this permits blood trapped in the veins to be released. Repeat the above steps to confirm the accuracy of the reading, especially if it falls outside the normal range, although this may not be routine procedure for hospitalized or well clients. If there is greater than 5 mmHg difference between the two readings, additional measurements may be taken and the results averaged. 9. If this is the client's initial examination, repeat the procedure on the client's other arm. There should be a difference of no more than 10 mmHg between the arms. The arm found to have the higher pressure should be used for subsequent examinations. Fonseca Reyes, Forsyth McQuarrie, and Garcia de Alba Garcia, 2012. Variation: obtaining a blood pressure by the palpation method if it is not possible to use a stethoscope to obtain the blood pres. Sure, or if the Korotkoff sounds cannot be heard, palpate the radial or brachial pulse site as the cuff pressure is released. The manometer reading at the point where the pulse reappears is an estimate of systolic value. Variation: taking a thigh blood pressure help the client to assume a prone position. If the client cannot assume this position, measure the blood pressure while the client is in a supine position with the knee slightly flexed. Slight flexing of the knee will facilitate placing the stethoscope on the popliteal space. Expose the thigh, taking care not to expose the client unduly. Locate the popliteal artery, see figure 29 to 13. Wrap the cuff evenly around the mid-thigh with the compression bladder over the posterior aspect of the thigh and the bottom edge above the knee. Rationale: the bladder must be directly over the posterior popliteal artery if the reading is to be accurate. If this is the client's initial examination, perform a preliminary palpatory determination of systolic pressure by palpating the popliteal artery. In adults, the systolic pressure in the popliteal artery is usually 20 to 30 mmHg higher than that in the brachial artery. The diastolic pressure is usually the same. Variation: using an electronic indirect blood pressure monitoring device, see figure 29 to 20, page 502. Place the blood pressure cuff on the extremity according to the manufacturer's guidelines. Turn on the blood pressure switch. Measuring blood pressure in a client's thigh. Continued on page 506. M29B_Berm 4362_10_SE_CH29.IND 505 February 12, 14, 5:51 p.m. 506 Unit 7 Assessing Health. Number 153613 CUST, Pearson O. Berman PG Number 506 Title, Kosier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K /Normal Design Services of S4 Carlisle Publishing Services. Assessing Blood Pressure, continued. Skill 29 to 6. Evaluation relate blood pressure to other vital signs, to baseline data, and to health status. If the findings are significantly different from previous values without obvious reasons, consider possible causes, see Table 29-5. If appropriate, set the device for the desired number of minutes between blood pressure determinations. When the device has determined the blood pressure reading, note the digital results. 10. Remove the cuff from the client's arm. Safety alert. Electronic/automatic blood pressure cuffs can be left in place for many hours. Remove the cuff and check skin condition periodically. The client uses it for the length of stay, and then it is discarded. Rationale: this decreases the risk of spreading infection by sharing cuffs. 12. Document and report pertinent assessment data according to agency policy. Record two pressures in the Form 130/80 where 130 is the systolic, phase 1, and 80 is the diastolic, phase 5, pressure. Record three pressures in the Form 130/90/0, where 130 is the systolic, 90 is the first diastolic, phase 4, and sounds are audible even after the cuff is completely deflated. Use the abbreviations RA or RL for right arm or right leg, and LA or LL for left arm or left leg. 11. Wipe the cuff with an approved disinfectant. Rationale: cuffs can become significantly contaminated. Many institutions use disposable blood pressure cuffs. Report any significant change in the client's blood pressure. Also report these findings: systolic blood pressure of an adult above 140 mmHg, diastolic blood pressure of an adult above 90 mmHg, systolic blood pressure of an adult below 100 mmHg. Lifespan considerations: blood pressure. Infants use a pediatric stethoscope with a small diaphragm. The lower edge of the blood pressure cuff can be closer to the antecubital space of an infant. Use the palpation method if auscultation with a stethoscope or DUS is unsuccessful. Arm and thigh pressures are equivalent in children under 1 year of age. The systolic blood pressure of a newborn averages about 75 mmHg, D'Amico and Barbarito, 2012. Children blood pressure should be measured in all children over 3 years of age, and in children less than 3 years of age with certain medical conditions, example, congenital heart disease, renal malformation, medications that affect blood pressure. Explain each step of the process and what it will feel like. Demonstrate on a doll. Use the palpation technique for children under 3 years old. Cuff bladder width should be 40%, and length should be 80% to 100% of the arm circumference, figure 29-24. Take the blood pressure prior to other uncomfortable prostors so that the blood pressure is not artificially elevated by the discomfort. In children, the diastolic pressure is considered to be the onset of phase 4, where the sounds become muffled. In children, the thigh pressure is about 10 mmHg higher than the arm pressure. One quick way to determine the normal systolic blood pressure of a child is to use the following formula. Normal systolic BP 581, 2-3 child's age in years. Older adult skin may be very fragile. Do not allow cuff pressure to remain high any longer than necessary. Determine if the client is taking antihypertensives and, if so, when the last dose was taken. Medications that cause vasodilation, antihypertensive medications, and also the loss of baroreceptor efficiency in older clients place them at increased risk for having orthostatic hypotension. Measuring blood pressure while the client is in the lying, sitting, and standing positions, and noting any changes, can determine this. If the client has arm contractures, assess the blood pressure by palpation, with the arm in a relaxed position. If this is not possible, take a thigh blood pressure. Figure 29-24 pediatric blood pressure cuffs. Safety. M29B_Berm 4362_10_SE_CH29.IND 506 February 12, 14, 5:51 p.m. Chapter 29 Vital Signs 507. Number 15361